surgical pathologies before you could really practice cytopathology. And it's very difficult to even educate our own scientific community that by labeling people, you are not really accomplishing anything. We need to just together work through the process of improving our ability to better serve our patients. Continue to the concept of what is really the value of fine needle aspiration biopsy as its own diagnostic, really ability. This is just an example. This is an old slide when I had looked at 3,000 palpable breast lesions with histologic follow-up and tried to look at what is the rate of insufficient cases, their sensitivity and specificity. And you can see this is a pretty good, really, performance, so to speak, in palpable breast lesions. But when we apply that to non-palpable breast lesions, you can see that the rate of insufficient cases of almost close to 20% make it almost very difficult to try to convince that we can use the same thing in all of the non-palpable breast lesions. And that has been, with advances in breast imaging, with better localizing devices, with the interest of radiologists and, of course, surgeons in these days and age, fine needle aspiration biopsy has fell out of the favor, and very, very rarely it is really being used. And it has been replaced by core needle biopsy, which has the ability to sample the lesion. And of course, these small fragmented tissue biopsies are very familiar to general surgical pathologists, and they really love that compared to fine needle aspiration biopsy. And again, core needle biopsy has the ability to provide diagnostic information as well as all the prognostic information that we use in clinical practice. However, when you really review the literature and look at the function and the performance of fine needle versus core needle biopsy, we recognize that the same limitation or diagnostic challenge that exists in fine needle aspiration biopsy, the same exists in core needle biopsy. Because when you really look at the listing of atypical diagonal hyperplasia, DCIS, papilloma, lobular neoplasia, and so on and so forth, you see that the cases that they have been diagnosed with these entities by core needle biopsy, on subsequent surgical excision of the samples, you have seen the incidence or increased incidence of malignancy up to 24 to 25% of these cases. And this is, again, an area that we all recognize that, and we have to be careful that when you diagnose a case of atypical diagonal hyperplasia, there's significant chance that in lumpectomy or surgical excision, you can have in situ and invasive lesions, or for that matter, when you have DCIS, you may have invasive cancer in subsequent surgical biopsy. So the difficulty or diagnostic challenge are pretty similar. So to put all of this information together, I think fine needle and core can and should be utilized together for the best management of patients with breast lesions. However, radiologists and clinical findings, radiologic and clinical findings should guide the decision as to which procedure should be used. And difficult to diagnose lesions are similar in fine needle and core needle biopsy, and the triple test plays a critical role in the accurate interpretation for both. This is what we like to see. We like to see the palpable lesion. Fine needle will be the first line of sampling technology. If it is benign, we can follow it up. If it's malignant, the patient can undergo therapy. And if it is indeterminate, either the core biopsy or surgical excision should be performed. For non-palpable lesion, if you have a cystic lesion, ultrasound-guided fine needle can very easily provide a good diagnostic, sample. And if it is solid or you have microcalcification, core needle biopsy can very easily provide diagnostic material that we need. The follow-up of the patients in this scenario is very similar to what we advise for fine needle aspiration biopsy. And with that, I'm hoping that one of these days, when cost containment becomes something more serious that we all can do, and especially in an international environment and in international community, we would be able to really look at fine needle aspiration biopsy as an effective way that we can sample palpable breast lesions at least, and try to really bring it on board in respect to ability to train our cytopathologists and our pathology residents, so that this very, very important component of our really discipline does not really fall and it just doesn't go away. And of course that really requires a very concerted effort among all of us to try to really look at, again, less expensive and less problematic way of sampling birth regions. And with that, I thank you for your attention.
Thank you very much, Dr. Massoud, for this very comprehensive and illustrative talk on the cytopathology of the breast cancer. And I would like also to thank Dr. Sahim for her lecture. Now, any questions?